Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to the Voices of Otolaryngology. I am thrilled to be here on day 2 of the Oto Forum in April 2025 from Alexandria, Virginia. You know what I've been saying this whole meeting? Sometimes you just get lucky. And I just made a new friend, and I'm really excited to show him off to you all, right? You make a new friend and you want to bring him home, so I brought him home to our podcast studio.
Thank you.
And throughout this, we're going to learn about his story, but we're really going to focus on in-office surgeries. So we're going to have a little bit of fun, get to know him, but we really want to go into in-office surgeries. He told me he's a country boy. He doesn't know how much I love country music in Nashville, so I might be a pretty big country
music
boy.
USA.
Yes, sir. Yes, sir. I can probably dance circles around you with music. But so we're gonna get right into it.
Sure.
All right. You're a very special guy, and you're a Nashvilleian, if that's a word. You grew up in that area.
Correct.
Did your training in Texas and came back home, and your practice has been around for decades.
Correct. We started our practice back in 1973. I went to college in Texas, but did my ENT training at Vanderbilt. So
that's wonderful.
Yeah.
And then you stayed in the community.
Stayed in the community.
You've always been in private practice?
Yes, for 27 years now.
Okay. And your friends, they call you Lee, they call you G, they call you Bryant?
Or Grady Lee. So
Grady Lee.
I answered anything.
Okay. Well, I'll just call you Dr. Bryant out of respect today. And let's just get into it. You're a survivor. You're a cancer survivor, and that's really amazing. Just before you started, I got chills because you said, you've grown up on a farm with chainsaws, everything. And what's amazing though, you lost your thumb for cancer.
Yeah, that's correct.
Not
from
the farm.
a chainsaw. That's right.
Do you mind telling us about
Sure.
that? I mean, your story's amazing.
Story's kind of amazing, but a few years ago, I had a little dark spot on my thumbnail. Not the kind of cancer you get from a melanoma from a skin cancer, or sun exposure, but it's called an acral melanoma. But I did the right thing, went to the dermatologist, and they thought that that may be melanoma. So they arranged for a biopsy, and the biopsy came back benign inflammation. And I was elated, and so time went by, and multiple consultations, and poor healing, and continued pigmentation, and I was concerned that it could still be melanoma. So after multiple people telling me that the biopsy was benign, don't worry, I actually in my office biopsied my own finger, and unfortunately, it was I got the diagnosis of melanoma. So the journey in 2000 during COVID was basically a partial amputation of my thumb and actually no dissection and a year of chemoimmunotherapy. And
wow.
And again, the prognosis was not great, but so far my scans have been clear, and so I've had to be a survivor and regain balance in my life and also learn to operate with half a thumb, which I've been able to do. So wow. I feel very blessed, and I'm happy to be here and happy to be part of the OPPS in this forum. So
and what year was that?
2021.
Yeah, so 4 years out. So amazing.
Yeah.
Well, congrats, man. That's incredible.
Thank you.
I can't believe you biopsied your own thumb.
That's the
I mean, you're a little.
I'm a right-handed surgeon.
Right-handed surgeon.
Lost half my thumb, but I did with my left hand.
Wait, so with your left hand you biopsied?
Removed my nail and biopsied the nail matrix and cauterized it.
And did you numb up before you moved?
A little bit, but it was. I just had to do it. So.
Wow.
And if I hadn't, I probably wouldn't be here today. So I was just anyway, so
wow.
Yeah.
Well, thank you for
it's quite the story, but it's good to so I have a little blog out there that talks about being a cancer survivor, a physician becoming the patient, melanoma awareness, and a little bit of faith in there, but it's drleebryant.com, a little plug for that, but it tells my whole journey, and you live your life differently, and you really it changed my relationship with my patients. That's been the physician-patient relationship has become a different one, and I've learned about engaging the patient, and they're aware through this blog my diagnosis, and so there's been prayers, and there's been tears, and there's been hugs, and it's I've learned it's okay to open yourself up to patients, to show emotion, and to put your hand on their shoulder when you tell them a diagnosis, and it's. I think we lost some of the human because of medical legal issues. We sort of lost that human, the art of medicine, and being the complete physician. And so, and I was the same way because you're afraid of whatever. But I think in my position, it's changed the game a little bit, and it's brought me back to why I became an otolaryngologist. And so, anyway, for whatever that's worth.
Yeah. So the blog is Dr. Lee Bryant, BRYANT.com.
Correct.
There's no plug for that, man. We want to learn about it. drleebryant.com.
That's
well,
it.
thank you. That's really
yeah,
amazing.
Yeah.
So I've grown up in the suburbs, went to Boston, did all my training, the farthest thing from a country boy.
Yeah.
But I can imagine when you told your family what you did, they probably said, Grady Lee, you did what? Is that kind of how it sounded?
Yes, that's how it sounded.
Yeah.
And the medical oncologist, the surgical oncologist,
everybody said
the ortho oncologist, the first thing they would ask me, now tell me, you removed your own tumor? And I'm like, I really did. So anyway, so it also is important clinically if you've got leukoplakia in the mouth or a lesion in the larynx or wherever, the importance of it's okay to re-biopsy if something's still hanging around.
Doesn't that astound
quick
you?
to biopsy.
We could have a whole podcast on that. We are experts. We have means. We have intelligence. Everybody kept telling you. It's benign. It's benign.
Don't worry.
You wouldn't be here, man.
I wouldn't be here for sure.
So isn't that amazing?
It's amazing.
And we're lucky.
But it's important with my I'm a general ENT, focused on in-office rhinology, but I still do a lot of everything, still treat head and neck cancer. And so it's importance of, if you're concerned, perform another biopsy, be vigilant. And
that's what you mean. It's changed your practice a bit. If something's not adding up, you said it had poor wound healing.
Right, correct.
Yeah.
Correct, yeah.
Well, let's go right into it. Thank you for that.
Sure.
But in-office surgery, we're going to forget about your head and neck practice, and I'm going to rapid fire some questions if you don't mind. So let's assume 5 days a week. So that's 10 half sessions. What does a typical month or week look for you? How much are you, those half sessions, are you in the office, in the operating room, surgery center? Just a little bit. Tell us about that.
I would say I do 3 days a week clinic.
So that's 6 half sessions.
Correct. Okay. And then a full day in the operating room.
On the main
hospital. Surgery center.
Oh, surgery center, okay.
And then I spend a half day a week doing office surgery.
Okay.
And some days there's a little more office surgery in there, but typically it's a half day a week.
All right, so 3 office days producing 1 ASC day and about a half of office. So that's the volume.
And maybe another half day in there.
If you need to catch in there. Okay, and I know there's nights and weekends and evenings, but we didn't count that. All right, and then tell me about your practice for our audience to know. It's all ages, or do you have a kind of a subspecialty niche within your group?
We're all general otolaryngologists, and we've got 8 physicians, 7 of which are otolaryngologists, 1 of which is a general surgeon who does our endocrine surgery. She's an endocrine surgeon. Then we have 5 APPs, and we have 3 offices and 80 employees. We've our group has been around since 1973, and it's been a great professional satisfaction for me, a great practice. And Dr. Scott Fortune, he's well known as well in office surgery. We're practice partners. We sort of partnered together we were some of the innovators in this field, and he's just written in press, Otolaryngology Clinics of North America, 2025, the sort of how-to for patient selection, setup, and anesthesia for office surgery.
Wonderful.
So we sort of partnered together, and honestly, we went around the country. We went to many centers. It was in its infancy, and so we went around the country separately. And so let's travel around. Let's look at best.
When did you do this? 3 years ago?
It was probably 2010.
Okay, sorry. Yeah, so 15 years ago.
And then we said, we're going to look at the best practice. We're going to bring that back and piece it together and figure out what really works. And what led to that was I was going to the OR pre-2010 doing turbinate reductions, general anesthesia for a simple turbinate reduction. And there was a lot of resources for a minor operation. These are patients with nasal allergy that had trouble breathing, patients that couldn't tolerate their CPAP machine for a variety of reasons. And I'm thinking, there's got to be a way to do this in the office. And my father's a dentist, and I did some rotations in oral surgery in medical school. I learned
you can extract a tooth in the office. You can do turbinate
there
reduction.
There you go.
Was that the rationale?
That's the rationale, exactly.
Yeah.
And so the first shavers came out that had this reusable blades, which made economic sense. And so we taught ourselves to block the nose, sphenopalatine block, and to do simple turbinate reductions in the office with great success. But
Dr. Bryant, it's got to be bleeding.
It bleeds so much less in the office. It's incredible. Sometimes I'm in the OR doing a sinus case, and I'm thinking, I wish I did this case in the office because.
And I have heard about that, and you've thought about it. Have you thought about the pathophysiology of that? I've heard about that from a lot of people.
So several things. In the operating room, if you look at what they're giving your patient fluid-wise, they may end up with 1.5 liters of fluid.
They're tanking them up.
And so what does fluid do at third spaces and where? To the wound. So there's tissue edema right there. And you think about the blood pressure swings that you have with the anesthesia, and then on top of that, the vasodilation you have, the vasodilatory properties you have from the inhalational gases. All that leads to incredible swelling and bleeding. And so when we do traditional FEST, not just a minor non-invasive case, we rarely suction the patient. They're laying flat, and you rarely use your suction.
Hold on just a second. You said you do traditional FEST in the office.
Correct.
I don't even understand that. That's fantastic. And your patient is what level? What do you give them? You give propofol in your office?
No, it's local anesthesia.
I'm just kidding around, sir.
Some offices do.
No, I'm just kidding. Do you give any anxiolytic?
We do. We pre-medicate at home with diazepam, little promethazine, little Tylenol.
But you keep them NPO for real? Like, do you just in case there's an emergency?
Not really.
You don't?
And then we give local blocks. And so it's all about the local block, the sphenopalatine block. But we became adept at in-office anesthesia, doing these simple turbinates, nasal polypectomies, and that's when the balloon dilation era came out, 2010 to 2014.
So you became very slick.
Well, we were already working in the nose and the wake patient. We were comfortable. So then the balloons were a nice. That was a natural evolution for us. And then with the advent of image guidance,
you might as well just do a pituitary. I mean, it's a natural evolution. Let's just go back a little bit.
And I do those, but not in the office. But we've taken off, skull base inverting papilloma in the office. Believe it or not, I've got the videos to prove it. But with balloon dilation, and then the image guided systems that were more affordable came to be. And when that came into the office, we started doing septoplasty and traditional.
All right, let's go step by step, because I told you I'm a country boy that loves Nashville, and you know where Garth Brooke lives, and you haven't
I've got friends in low places now.
Yeah, but you haven't invited me to your practice, man. I'm gonna come. I want to check out your practice.
Come on down.
All right, thank you for the invitation.
We'll see Garth Brooks farm, and we will hear some country music.
And then I want to actually see your office space. Yeah. So let's pull back a second. In your office, you have created a little space?
Correct.
Okay, talk about that space, because it looks like you have image guidance, you have a certain bed.
Yeah, so this is what I think that I think it's the future of our field, and we migrated from the OR to the surgery center space, and now to the office, where patients have no hospital bill and have no anesthesia bill. It's a great thing for the patient. Recovery is much faster because of the capital.
Dr. Bryant, society's moved that way.
Yeah.
So sorry, they want more instant stuff. I interrupted you.
No, that's fine. It's been great, but I think that there is a capital outlay. There's a certain skill set that one needs to work on the awake patient. I'm hoping that from a coding perspective, maybe the reimbursements will increase for the office to drive some of this to the office, but we'll see. But anyway, our office space has a regular chair, a regular SMR cart. We have a nice video tower. We have to have a suction, have to have a shaver, and we have our image guidance.
You do have the image guidance in the office.
And there's a lot of sweat equity in training. My nurse is the pre-op nurse. She's my scrub nurse. She's my circulating nurse. And she's my PACU nurse.
And if she leaves, you're done. You know what I mean? You've taken a lot of effort.
We've got cross-training. There's a lot of effort. And it's fun for them. And if they're in clinic all day, every day, it can get a little redundant. And they love the OR day because they're watching the surgery on the screen.
So do you have an in-office scanner?
We do not.
So then image guidance, where do you get the scan?
They come from the scanners that we use, the different radiology centers.
The radiologists,
and they come on a thumb drive, upload those, just like the OR. The anaphylactomy is the same in the office as it is in the OR. Septoplasty, it's the same. There's multiple ways to do septoplasty. You can do a limited, the track balloon septoplasty. You can do a endoscopic vertical incision, a targeted septoplasty. We can also do a traditional hemitransfixion, submucous resection in the office. And I've had multiple rhinologists come to visit me that didn't believe it could be done in the office. You almost have to see it to believe it. But believe it or not, 10 days out, an in-office septoplasty looks healed. 10 days out, my OR septoplasty has edema and they're miserable. It's a big difference.
So,
but you got to see it.
Full disclosure, I have a deviated septum, and I trust nobody to operate on it. Maybe I'll come to you and you can do it away. All right?
I'm not sure because I don't want to violate HIPAA, but there may have been a chairman of a department back in the day that broke his nose and had me fix it. And I was concerned about who was going to see this nose for the rest of my career. So I won't name any names.
So let's go through the gamut of what you offer. You turbinate, septoplasty, complete functional endoscopic sinus surgery,
Correct. So the evolution from turbinate reduction to balloon dilation to what I would say hybrid cases, balloon plus ethmoid and/or septum. And now we've expanded to other disease states. Lots of technology. So,
But you're only in-office rhinology, or no? That's what I mean. Go ahead, keep going.
I, for the most part, I am. But I would consider dexamethasone.
Oh, sorry, you do finger surgery too.
Finger surgery.
Only thumbs.
This one, another one will make two.
Yeah.
But we have, intratympanic perfusions for ears. A lot of offices do, laryngeal injections we do Botox for TMJ. So, I mean, there's a lot of things fall in the realm of office surgery, but your trainees they're adept at rigid and flexible endoscopy. It's not much of a step. It's about learning the local anesthesia. And and I think, like I say, this evolved because I thought turbinates could be done in the office, and it just kind of sort of grew from there. And Scott Fortune partnered with me, and again, it's been a renaissance, something new and fresh, a renaissance in our career to have something new to offer patients. And it's a bridge between medical therapy and now, balloon dilation at all is a step, but it's not going to the operating room. And many people will take that leap of faith before they'll go to the OR. And the age of high deductibles, if that's a high deductible, it's just our fee, so it's cheaper for them and a quicker recovery, less time off work. And so we've got 7 surgeons, all of whom our in-office suite is going every single day, all day long. So that's great.
Because you were certain days, you're on there maybe Wednesday, Dr. Fortune, in the in-office suite.
And
wow.
Not to mention numbers, but revenue per case for us in the office is twice of that in the operating room. Yeah. So really, for our time spent, it helps. In private practice, it's important to...
but it's also access.
Keep the doors open.
It's revenue, it's access. You're getting patients what they need at the right site.
It's patient-centric. They're getting good operations with great outcomes, with quicker recoveries. I'm so passionate about it. It's not gotten old. To this day, it just blows me away when I have a patient that can't tolerate their CPAP. They have a contrabulosa on one side and big inferior turbinates with hypertrophy. And I'm in that turbinate with a shaver, and I'm just bouncing around with no bleeding. And then the in fracture and the out fracture, and they hear the crack. And it's like, how do we do this in the awake patient? But they just tolerate it great. And it's a quick recovery, and it's still fun.
You look back historically, and that's how they used to do it. And patients tolerated it, even without and it's almost that the awake patient does better.
They do better.
Physiologically.
I think that weren't tonsils done under awake patients back in the day?
Yeah. There were some countries where you'd sit right up and they'd put snares while you're awake, hold your head and yank them out.
Yeah.
And the bleeding stops.
Yeah.
Because the pharyngeal constrictors brought it together. Even adenoids, they would just swap. Yeah, you're absolutely
amazing.
Right. So I interrupted you earlier. You said you have expanded to other disease indications. I want to get you back on that.
Right. So if for the generally otolaryngologist that treats nasal obstruction, nasal congestion, et cetera, allergies. When we had a patient in the past that had nasal valve issues, I think that for a lot of us that aren't doing the open approach to the nose regularly, we feel like, and we want to offer to our patients those interventions that we feel that we're confident doing, that we do a lot of. And so I think for a lot of us that don't open up the nose, we would refer those to facial plastics, and we would address the valve with spreader grafts and that sort of technique by referral. And there's other technologies, lateral wall implants, there's radiofrequency ablation. And so we have mechanisms to address the nasal valve now in the office with great success.
And you do that?
We do. And then also vasomotor rhinitis treatment of, so we're already...
You know about posterior nasal nerve ablation?
It's amazing.
It is amazing. I'm super excited about it.
I was not a believer.
Yeah. I've seen the data.
You have to see it to believe it.
I have seen the data.
It's amazing. I was not a believer in balloons. I was anti-balloons, and I became a believer as well. So sometimes you have to see it to believe. And I've got my theory on the balloons, but they can be controversial.
Yeah. So that you do posterior nasal nerve ablation, you do nasal valve.
Correct.
All right. Any other indications?
Eustachian tube. Eustachian tube balloon dilation is a great option for patients who have barotrauma in particular, or patients who have recurrent effusions. And we've had great success with Eustachian tube balloon. That's very well tolerated in the awake patient. So
it's also probably very safe in an awake patient.
Very safe,
right? You won't overdo it.
Won't overdo it. So we've had Those are other kind of disease states or branching out from the things that we've been doing in the past few years, and they've been great interventions.
This episode of Voices of Otolaryngology is brought to you by
CPAP works for many. We're here for the rest. With over 100,000 patients treated, Inspire therapy is expanding across ENT practices nationwide. It's a minimally invasive, outpatient procedure for moderate to severe OSA, implanted in less than 90 minutes. Over 300 million Americans have insurance plans that cover Inspire therapy. Close the OSA treatment gap with Inspire therapy. Learn more and review important safety information at inspirefortherest.com.
Yeah, I'm just going back. These podcasts are all about me, and I'm thinking when to visit your practice. When you have a country musician in there for a balloon dilation, just happen to call me and I'll drive down.
Well,
I love them all, the early ones, the senior ones.
Well, you laugh, but if you're an otolaryngologist in Middle Tennessee, you have patients, those singers as professional artists as your patients of all genres, because Nashville has lots of recording. And my grandfather was a studio musician. He was a professional musician in Nashville when country music kind of started.
Yeah, the Grand Ole Opry is one of my favorite places.
He was the first drummer on the Grand Ole Opry. Believe it or not, in country music,
let's go.
The upright bass was the percussion. Yeah. It was considered too rock to have drums. Yeah. And so they said, we want a country drummer. Yeah. And so he recorded with Buddy Holly and Elvis Presley. Oh my God. But believe it or not, they said, we need a country drummer. And he was the very first country drummer in Nashville. The A-list musicians, they played the sessions, road bands went out, but he was the first drummer on the Grand Ole Opry. The first time he set up drums, they threw him off the stage. Loretta Lynn had him thrown off the stage, but eventually they accepted drums.
I get it, though. That's a great bit of history for me.
So, anyway,
I love the Grand Ole Opry.
I digress too much.
I just walk in there. I love it. I mean,
it's wonderful.
You see really amazing stories. Yeah. Can we talk a little bit, and remember, this has a huge audience of listeners, so be careful how you answer this one. Safety. Talk to me a little bit about safety, and don't tell me everything's always safe. And you don't have to talk about your practice. You're lecturing today at Oto Forum. What are you seeing across the country and around the world? What could go wrong, and how do you mitigate that?
So we obviously have a crash cart.
Okay.
We treat these procedures seriously. So it's much like an OR day case. We have a whiteboard with the patient, the date of birth, the procedure we're doing, when the platelets were placed, when everything was done, and then we do a timeout.
But it's you and a nurse. There's no surgical tech.
Correct.
It's you two.
Correct. The two of us.
It's just you two, and you still have a whiteboard.
And we still to this day, when we're mixing medications, we have two nurses and a physician watches to make things safe. So it's very much the same. These patients are monitored with a blood pressure cuff and pulse ox and et cetera. But I think that, and so we're allergists, so we're prepared for anaphylaxis. We're prepared for resuscitations. I do think I've trained a lot of physicians over the years, lots of guests to watch us work, and I think the days they learn the most are the days that something goes wrong, because and
I'm sorry to say that, but yes,
because they see how we deal with it, and it's different. There's the art of medicine. Typically, we're laughing, we're talking, we're telling jokes, and it's a great day. That's the typical day. But occasionally something happens. And one time I had guests, and the patient was a little bit oversedated in the procedure. The sats were dropping down to the high 80s, and they were snoring. And
let me interrupt. Oversedated with IV sedation?
Nope, just with the pre-medication.
Which is.
We've had various protocols. This was triazolone. Now we use
diazolone. But felt a little oversedated.
And so we just stopped the procedure, and we told the guests, hey, it's okay to stop and reassess and figure out. But we've not had any major complications.
So tell me about that patient. So you just stopped, kind of waited.
Raised them up out of the supine position, gave it some time
for that oversedation.
Monitored the patient. We were halfway through. We had a chat with them. They wanted to proceed. We laid them back down. We did the procedure. But what we did was stop.
That's a lot of integrity, Dr. Bryant.
And we were willing to put a pause and to reassess and to do what's right for the patient. So we have very, very few complications. With regard to bleeding, we have a suction cautery in the office, which I will use to control a nosebleed, but I've never had to use it on a sinus case. Not once.
You mean a straight up suction cautery you plug in the wall and you have that ready to go?
But I've never had to use it on a I think Dr. Fortune, who does a lot of these as well. I think one time he used it.
Your local is so good.
And so good.
And
Pledgets.
Any laryngospasm? I mean, where the blood will drip down.
There's no.
And I don't mean to jinx you.
There's not much. There's very little dripping down. So sometimes we'll suction the nasopharynx, but we're real careful on the topical pledges to wring them out.
Yeah, good point.
So that there's no drip. So they're not numbing. If they're numbing the throat, they're coughing the whole procedure. They're uncomfortable.
Yeah.
So. And I mentioned all of this in our session at the forum yesterday, but it's the bleeding is so much less. And then with regard to the image guidance, I grew up in the era of pre-image guidance, and so that gives you an extra layer of safety. It doesn't replace your awareness, but also in the awake patient, they can feel the light, they can feel when you're close to their lamina, they can sense when you're close to their skull base. So there's a little bit of feedback.
Well, what do you mean a little bit of feedback? What do they say?
Well, you can say, I feel a little pressure on my eye. I mean, you actually get
they say that.
Yeah, you can get you have tactile feedback, you have the image guidance, you have some patient feedback. And it's unbelievable. And a neat story on a patient who had an endoscopic sinus surgery elsewhere. They had a right ethmoid mucocele, and it was just one sinus. And I said, we can do this in the OR, in the office. And so she opted for the office. And so our suite has, two of the walls have windows. And so it was under image guidance, and I drained this mucocele, and I was up against her. It was putting a lot of pressure on the lamina, on the orbit. And so.
But that must have been a super fun case. Come take that into your wall down, drain the mucocele,
drain the pus out. And so.
That's awesome.
When I was putting the pledget in there, when I finished, she started crying. And I thought she was in pain. I said, "What's wrong with you?" And she said, "Dr. Bryant, when I sat in this chair, it's been affecting her vision." She said, "I couldn't read the hospital sign across the street.
Oh my God.
And I can read it now." And it was amazing that her vision had improved immediately from the pressure. So it's kind of neat that you wouldn't experience in the operating room. I've seen that with pituitary tumor patients that felt like they could see better in the PACU, but it was kind of fun to see it in real time.
Case.
Yeah.
So they feel pressure on their eye. I wonder how it feels to feel pressure on the brain. When you said you're at skull base.
Well, there's
get a little light in my brain.
Yeah, but now we have feedback from the image guidance, but sometimes there's one more cell up there and what you're pushing on. You're not sure if it's the fovea or if it's but one more, you're pushing pretty hard and they feel nothing. It's in the image guidance says you're okay, and you may be a little more brave to take another little more tissue out to get to the fovea. But it's there's a little patient feedback, and I imagine if you were doing something that may potentially could hurt the orbit or cause an intracranial injury, I think they would probably feel something. So
the body's resilient and responsive.
In all fairness, the evolution from balloons to sinus surgery, I started doing septoplasties and ballooning, but I went and saw some experts in the field do in-office ethmoidectomy. I was kind of afraid to do it, anxious about anxiety. But one day I was trying to balloon a maxillary sinus, and because of the prominent ethmoid bulla and the anatomy, it was tough to make the angle, make the turn. I thought, I've seen this done. I'm just gonna poke in the bulla and see what happens. And nothing happened. The patient didn't notice it, and then it just took it down.
Because you numbed it off, you injected.
Took it down, and so then started doing adding the hybrid cases. And so, if we think about the evolution of sinus surgery, I practiced in 1970. Dr. Haran Yagoda started our practice 1973. He was trained at WashU under Ogura, and he did Caldwell Lutz and inframeatus antrostomies. And then in his career, the middle meatus antrostomy came to be, and Dr. Kennedy and Hopkins in the 80s and the endoscope, and so endoscopic sinus surgery. Then a lot of those were done, and people failed, and we learned the importance of incorporating the natural os. And so we've all dealt with circular flow and openings that were not incorporating that.
Yes.
So functional endoscopic surgery is to make sure the natural os is included. And so what's the most functional thing we can do? That would be to dilate that os and preserve that natural outflow tract of the osteometal complex. And people ask me, why do you think this works? And so when I would do these balloon cases, inevitably when these cases were done for mostly recurrent acute sinusitis, sometimes chronic, they would come back and say, "Doc, I just breathe so much better. I just feel so much." My results with balloons in the appropriate way, not abusing, but used appropriately in the right cases, indications. The results were phenomenal. I wasn't a believer, but I was trying it, and so I tried to piece together why. And I think the why is we've all had those patients who have uncinate that's plastered up against the covering the natural os, and then we've got that lateralized middle turbinate. So when we're ballooning, we're not just ballooning an os, we're medializing the middle turbinate. We're anteriorly displacing the uncinate process, and then we dilate the os. And so that is, by definition, anatomically speaking, the hiatus similune inferior.
Yep.
And so when we dilate the frontal space, where again, we're going to medialize the middle turbinate, we're going to dilate that suprabular space and go in the frontal. That's the hiatus similuniaris superior. There's something about that ventilation process that opens things up. And in the right patient, that gives them a world, and they're amazingly better. So that was sort of after ballooning a few patients and seeing these results. I think that's what helps them. And we talk about being gentle with tissue and not, you can't be rough in there. Got to be gentle, treat it like a stapes. Anytime you disrupt mucosa, you bring the risk for scarring. So it's all about a very delicate balloon dilation and opening those spaces up. And we've had some great results. I think sometimes the balloon gets a bad rap, but it can be very, very useful.
Of course, yeah, like any technology. What were some of the questions yesterday that you'd like to share with our broader membership from your talk? Anything that stuck out at you as, oh, that was a great question, you want to share that?
I think patients were concerned about, how did we start this up? How did it come, the capital outlay, the expense, the training,
all right, so the economic side of it.
The economic side of it, and then the anesthesia. I think, and there's different. There's practices out there doing all sorts of.
And you said
things.
Dr. Fortune has something coming out in otolaryngology clinics.
The how-to,
and it goes into the anesthesia.
But some offices use in-office sedation, some do local with pre-med, some strict local. But there's different ways to do it. But I think it's all about the local blocks, the comfort of learning to do the sphenopalatine block, and that's one. If you have a comfortable patient, then the surgeon's comfortable, and so I've talked to several surgeons yesterday that are in different stages of the evolution that I went through that are like, what can we do to take it to the next step?
So I love cars, I love driving, and so I'll drive around. My kids were little, and I was doing something in the car, and my wife said tongue in cheek, "Oh, Daddy thinks he's a race car driver." All right, and the kid goes, "Dad, you can't be a race car driver. You don't have a team, you don't have a pit, you don't have anything else. You don't even have a race car." And it makes me think of in-office surgery. You don't just do it. You get the setup, you have the training, you have the nurse, you have the whiteboard, you have the crash cart. You're not just an in-office surgery guy, you're an in-office surgery team.
Correct. There's no I in team, and that's correct. And some of our younger partners that came out, they really had almost very little training.
Of course not.
So we trained
And you
them.
brought them up to speed.
We brought them up to speed, just
And
like
they're
you
doing
would.
it too.
They're doing it. We're all doing it, and
Really?
just like you would for. I know that in different programs, the allergy experience varies.
Yes,
but
exactly.
We're all fellowship trained with the AOA, and that's a robust part of our
In
practice.
your practice.
And so a lot of that was learned in practice as well. We're always learning. So at heart, I think I'm an educator. I love to share my knowledge. I'll help anybody. If it's going to help patients, people come and watch us do what we do, and we do that to help people and help patients. And I think your education does on top of residency, but there's a lot out there in the private practice setting where there's a lot of learning that has to take place for that practitioner, that surgeon, to get up to speed of what we're doing. But that's a lot of fun. So.
You remember when you and I were going through med school, what did they say? In every 10 years, our knowledge gets recycled in medicine. Isn't that right? Or 20 years, something like that, right? When you and I were going through, right? In 20 years, all your knowledge will be obsolete. Wasn't that right?
That's right. I think it takes a generation to really. I think endoscopic sinus surgery. It was a generation of surgeons, and now I think the minimally invasive sinus surgery. That's the next generation.
And so you know what they say now? The medical education now, it's getting replaced in 3 to 4 years. So your point is well taken about continuing education.
Yeah.
How was your talk well received by our 150 attendees at Oto Forum? Meaning you probably asked them, how many of you do in-office surgery? Just could you give me some numbers? Is it a significant minority? Is it more and more? Talk about what you're seeing nationally with the trend towards in-office surgery amongst private practices.
I asked a question. Of course, this audience probably is heavily weighted toward private practice.
Yes.
And administrators of private practice. And ask the audience, tell me how many, if you're a surgeon or administrator, how many of you are doing some type of office surgery? And I would say 75% raised their hand.
Wow.
I then asked the residents. We've had a plug for the OPPS. It's been a great meeting.
And you're on the governing council.
I'm a secretary. The private practice section is there to advocate and represent private practice and to help us become engaged and partner with the academy to do great things. And so Annette Pham's the president. We've sponsored multiple residents with stipends to come to the meeting. So we've had good
Thank
resident,
you for that. That's
resident
awesome. You have 10
participation.
residents here that were
great.
given a grant from a private otolaryngologist. Thank you.
So I polled them and I said, raise your hand if you're learning any of this in your training. And we had very few responses there. So I think there's not a robust experience. And I think there may be barriers in the academic setting for this type of
And very
practice.
few practices are doing the extent of what you do, or you're seeing more and more of it.
I think with regards to
I'm talking about septums and
I think
traditional
that's
fats.
probably minority, but I think many are treating the Eustachian tube, vasomotor rhinitis. They're treating.
And it's not
sinus.
so much further, right, to go cognitively and technically to a traditional fess or in-office septum.
It really isn't. It really isn't. And so when now in the era of minimally invasive septoplasty, you can make if you think about, you need access. So if you think about septoplasty, it's not about a dorsal and caudal strut and removing everything with a submucous resection. It's about access. And so if you think more of a targeted septoplasty, you can make an endoscopic vertical incision, take out that cartilage or bone, that spur, and then leave the rest. And you can just lay that flap down, passive approximation, and have a great result. And so you can do a targeted septoplasty, which is not as involved. Oftentimes the algorithms have changed. Now we get this whole, it's about the patient selection is 90% of surgical outcomes. And so what's the next step? Is it the office? Is it the OR? Does the septum matter? Some patients I'll say, hey, you've got a deviated septum, which is mild. You've got large inferior turbinate hypertrophy. I'm like, I'll do your turbinates in the office, which is easy and quick. And you may be happy, and the majority are, without the septoplasty. We avoided that piece. So, and if they still have issues, we can do the septum in the office, the OR. So now it's a whole different way of thinking of indications and that sort of thing. So.
You're almost convincing me. You've definitely convinced me to come to Nashville. And my wife doesn't actually listen to any of my podcasts. But if she did, I think she'd drive me down there to have my septum fixed because she's got to wear earplugs for my
Is there a nasal speculum in the studio here?
What do you, and we're almost wrapping up. I really appreciate your time this morning. What's the future?
The future.
And I know you think about it. Where do you want to go next?
The future. There's the future of office surgery, I guess. Not the macroeconomics of our field and that sort of thing.
Office,
but
where do you see? And you're one of the experts out there. What do you see as the future? And you've talked about laryngeal, you talked about Botox, you've talked about otologic. But just for your office, what's the future?
Yeah. So I think the future is, if I do honestly feel this is patient centric. I feel like that. We can now treat the patient in the office very well, and from an economic perspective.
So you talked about a posterior nasal nerve, anterior valve, or nasal valve. So it's the evolution of technology driving us.
That, and then if we can, without the cost of hospital bill or anesthesia, I think the future is that a lot of what happens in the surgery center may be driven to the office. I think that offices need to get on board, or they may be passed on by with this technology. It's going to help our private practice be financially viable. When I started practice, every single case I did was in a main OR in a hospital. Every single case.
Exactly.
Even the ear tubes and
Exactly.
kids. And then over my 27-year career, that's slowly evolved to where they went to the surgery center. But back in the day, the hospital had the image guidance, the surgery center didn't. So image guided sinus surgery, but then they got the image guidance. So then it mostly migrated there. And now a lot's migrating to my office. So I think that will continue to happen. And who knows, every 3 to 5 years, like you mentioned, in this evolution from turbinates to balloons to the image guidance in the office, and now other disease states, there seems to be innovation that leads to more minimally invasive treatment. So I think the future is, we'll see.
Really, really well said and thought-provoking.
Yeah.
The Academy continues to embrace our industry partners, and it's those industry partners that drive the innovation that continue driving us in office. That's really, really well said. Were you there at the opening session yesterday morning?
Yes.
Did you hear my great intro?
Yes.
Okay, good. I'm going to say it for the group here. And what I said is there's never been a more exciting time for otolaryngology. And you're getting me really fired up and excited because it's thinking about the next evolution. You're right. 30 years ago, I trained, it was all OR, main OR.
And I like to share with the residents that are attending, and we're teamed up. We have mentors that are teamed up. But it's, why did I pick this field? Am I professionally satisfied? And I'll tell you that I am. And 27 years in, and the joy of being able to care for both the adult and the pediatric patient in the office, in the operating room, with both medical treatment, medical conditions, and surgical interventions. It's a wonderful field. And then having been through this cancer journey the past 3 years, I've learned that the human condition and the privilege of the physician-patient relationship, and although we see lots of patients in a day, that one interaction with you, it's so important to their life. That 15 minutes with you, they're hanging their hat on every word that you say, and then we as otolaryngologists can impact health and human life in so many ways every single day. So it's a privilege and honor, and to help people hear better, beat cancer, sleep better, breathe better, all the different things. And so I think this in-office surgery has been a renaissance in my career. The cancer journey has kind of brought back to me the human side and the art of medicine, and realizing some of the joy that I got that brought me into the field. Sorry for the long-winded answer, but
I think that's almost probably a perfect way to end. I took this job with great excitement, and one of the highlights is meeting new people and making new friends. So you'll see me on LinkedIn, or when I visit your practice, maybe we'll film another podcast. I cannot wait to see your in-office suite. And I think it's going to be more exciting than seeing Garth Brooks or the Grand Ole Opry. Thank you. It's a new friend.
Thank you so
very
much. Thanks, Dr. Shaw. Thank you.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.